Hi there, my valued, highly treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services in your line of duty. So I humbly urge you to sit back and spare me part of your very precious time to share with you some of the precious tips which may prove useful in your line of duty. Welcome to part 52 of our pharmacotherapy MCQ series, which majors in neurology. The first question reads, Mr. T.O.J., a 69-year-old male patient, presents to your hospital. He has a past medical history of hypertension and hyperlipidemia, and your team has diagnosed him with Parkinson's disease. Currently, he takes levodopa-carbidopa combination for dyskinesia. So my question to you is, which of the statements below is accurate with regard to levodopa-carbidopa? Is it true that hallucinations are less common with a controlled release form of levodopa-carbidopa than with the immediate release formulation? Or is it true that the controlled release formulations have less bioavailability than the immediate release formulations? Or is it true that the absorption of this product may be decreased by taking high protein diets or starting high protein diets? Or is it true that carbidopa inhibits the enzyme L-amino acid decarboxylase? I'll give you 10 seconds to choose the correct answer. So apart from answer A, all the other three, that is C, B, and D, are correct. I would like to emphasize that levodopa-carbidopa is a combination of L-amino acid decarboxylase inhibitor by the name carbidopa and a dopamine precursor by the name levodopa, which is used in the management of PD, Parkinson's disease. Since levodopa is structurally similar to amino acids, consuming a high amount of protein can lead to competition between the amino acids and levodopa when it comes to transfer into the CNS for its therapeutic use. Therefore, patients should be counseled to keep their diet consistent so that the medication can be dosed to the desired effects based on how they normally eat. Don't eat erratic portions of proteins. Now, controlled release formulations, or the controlled release formulation to be specific, isn't fully absorbed from the gut, and thus its overall bioavailability is less than that of the immediate release formulation. Therefore, when patients are being converted from the immediate release to the controlled release formulation, the dose of the controlled release form should be increased by about 20%. Now, due to the constant amount of dopamine exposure with the controlled release formulation, patients can experience more hallucinations with the controlled release form as compared to the immediate release formulation, and that fact makes answer A wrong. And I would like to underscore the fact that carbidopa doesn't cross the blood-brain barrier. It only inhibits peripheral decarboxylase enzymes, so that levodopa is preferentially shunted into the CNS, where it acts to manage Parkinson's disease. Let's move to the next slide, please. And the question reads, levodopa can be used in the treatment of restless leg syndrome, which we abbreviate as RLS, although this indication is limited by the high risks for augmentation, that is worsening of the RLS symptoms during therapy. My question to you is, which of the dosing regimens listed below isn't appropriate? Is it carbidopa levodopa 25/100 milligrams immediate release tablets every night upon awakening with restless leg syndrome? Or is it carbidopa levodopa 25/100 immediate release tablet every night at dinner time? Or is it carbidopa levodopa 25/100 immediately release tablets every night at bedtime? Or is it D, carbidopa levodopa 25/100 controlled release tablet every night at bedtime? I'll give you 10 seconds to choose the correct answer. B is the correct option. Now we know that levodopa competes with amino acids for absorption in the intestinal wall. It may also compete with amino acids to cross the blood-brain barrier, which is the site of action. Therefore, carbidopa levodopa shouldn't be taken with high amounts of protein, since it delays and reduces absorption. Now, we should recommend to patients that they should take the carbidopa levodopa products separately from meals containing proteins for optimal absorption and pharmacotherapeutic effect. Now, the immediate release formulation is appropriate for restless leg syndrome and can be taken at bedtime to treat the same RLS. Now, if the immediate release formulation is available, it is appropriate for restless leg syndrome and can be taken upon awakening to treat the restless leg syndrome symptoms at that time. Now, the controlled release formulation is appropriate for restless leg syndrome and can be taken at bedtime to treat the RLS syndromes. So all those make answer B the correct choice, because among all those statements is the one that is not appropriate. So let's move to the next slide, please. And our next question reads, Mr. MTG, a 55-year-old male patient, is transferred to your neuro ICU 72 hours after admission at your hospital in order to better manage his severe agitation and seizure activity. He has a past medical history of gold stage 3 COPD, type 2 diabetes mellitus, and alcohol abuse. His inpatient medication list comprises of oral phenobarbital at a dose of 60 milligrams PRN. When the CIWA-AR score exceeds 20. Now that abbreviation stands for Clinical Institute Withdrawal Assessment for Alcohol Revised. It's an alcohol withdrawal assessment scoring system. So the patient should take 60 milligrams when the score exceeds 20, and haloperidol at a dose of 5 milligrams IV, Prorenata up to 4 times a day in case of severe agitation, and lorazepam at a dose of 7 milligrams per hour IV, titrated to maintain a CIWA-AR of below 10, and additionally thiamine at a dose of 500 milligrams IV thrice daily. On top of that, he takes 40 milligrams of prednisone for his COPD and inhales or nebulizes salbutamol at a dose of 2.5 milligrams 4 times daily. Now for his type 2 diabetes mellitus, he takes 1000 milligrams of metformin after breakfast and after dinner, and 10 milligrams of empagliflozin. Now some lab values are available in the morning, and they include a sodium level of 135, potassium of 3.6, chloride of 98, bicarb of 18, and a BUN of 18, a serum creatinine of 0.8, glucose levels of 108, and ketones are negative. The lactic acid level is 2.5, and the serum osmolality is 295. My question to you is, which of the medications listed below could be the cause of Mr. MTG's laboratory abnormalities? Is it phenobarbital, lorazepam, empagliflozin, or metformin? I'll give you 10 seconds to choose the correct answer. Lorazepam it is. Now the IV formulation of lorazepam contains propylene glycol, which may accumulate when lorazepam is infused at high rates for prolonged periods. Now just like to add that IV phenobarbital also contains propylene glycol, but it isn't our concern at this stage because this patient is on oral phenobarbital. Now metformin can cause elevated anion gap metabolic acidosis, but this is a rare occurrence and is unlikely in the setting of normal renal function like we have in this gentleman's case, and this should be accompanied by an elevated lactic acid level, which is not the case here. Now empagliflozin and other SGLT2 inhibitors can produce euglycemic diabetic ketoacidosis, but this patient from the lab results has no detectable ketone bodies, so answers A, C, and D are all wrong. I'd just like to emphasize that propylene glycol is a diluent contained in some common IV medications such as lorazepam, diazepam, and phenobarbital, and it can accumulate at high infusion rates. Now, care should be taken when infusions of such products such as lorazepam are done at rates greater than, for example, 5 milligrams per hour for lorazepam for more than 24 to 48 hours, particularly in the setting of organ dysfunction. Now, the metabolic acidosis produced by propylene glycol is accompanied by an elevated anion gap and an osmolar gap, and even lactic acidosis may also occur due to the metabolism of this propylene glycol. Now, just like to remind you that high-dose thiamine should be administered to patients with suspected, in this case, encephalopathy. Now, this therapy should be administered either prior to or concurrent with any glucose administration in such patients. Now, the activity of thiamine is dependent on magnesium, and therefore, if such a patient happens to have low magnesium levels, then the magnesium levels should be corrected for thiamine to work well. Now, just like to go back to the SGLT2 inhibitors briefly, That is empagliflozin, canagliflozin, and dapagliflozin, which are common in our market. They have been associated with an increased risk of euglycemic ketoacidosis. Now, this appears to be common in those with recently reduced insulin administration specifically. So just remember that in your line of duty. Let's move to the next slide. Mrs. D.A.M., a 77-year-old Caucasian female, is rushed to your accident and emergency department with an acute onset dysphagia by her daughter. And this daughter claims to have witnessed the onset of the dysphagia around an hour ago. This lady has a past medical history of hypertension, type 2 diabetes mellitus, coronary artery disease, status post 2 stent placements, which was done 3 months ago. Currently, she takes 5 milligrams of lisinopril orally once a day, 25 milligrams of metoprolol twice daily, 500 milligrams of metformin after breakfast and after dinner, and 81 milligrams of aspirin once daily, alongside 90 milligrams of ticagrelor twice a day. Your stroke team reviews Madam D.A.M. and diagnoses an acute ischemic stroke, and they order Alteplase. Now, the following results emerge from their review. The imaging shows a CT head with no evidence of acute intracranial hemorrhage. The labs show a serum creatinine of 1.6. The blood glucose levels are high, 324. The hemoglobin is 11.9. Hematocrit is 33.2%. The platelets are 205 within limits. The INR is 0.9. The WBC count is 13.2. And the BNP is 335. Some of the vital signs include a heart rate of 99, a systolic blood pressure of 175 with a diastolic blood pressure of 115, a respiratory rate of 16, and the oxygen sats are 99% on room air with a body temperature of 99 degrees Fahrenheit. The actual body weight is 105 kilos. The ideal body weight is 59.3 kilos, and the adjusted body weight is 77.8 kilos. This lady is 66 inches tall. So my question to you is, which of the regimens listed below represents the correct Alteplase dose for the treatment of acute ischemic stroke in this particular lady? Is it a dose of 94.5 milligrams with 10% being administered over 1 minute as a bolus, followed by the remainder being infused over an hour? Or should it be a dose of 69.8 milligrams with 10% of this total dose being administered via bolus over a minute, followed by the remainder being infused over 60 minutes? Or should it be a dose of 90 milligrams with 10% being bolused over 1 minute and the remainder being infused over an hour? Or is it true that Alteplase is contraindicated in Madam D.A.M.'s case due to ticagrelor therapy? I'll give you 10 seconds to choose the correct answer. So C is the correct answer. I would opt to administer 90 milligrams with 10% of it as bolus over a minute, followed by a continuous infusion over 1 hour of the balance. Now, the dose of Alteplase for ischemic stroke is 0.9 milligrams per kilo. Now, while this is a weight-based dose, using the total or the actual body weight of a patient, the maximum or the ceiling should be and must be 90 milligrams. It should never exceed. That makes answer A totally wrong. Now, for acute ischemic stroke, IV alteplase is always administered in such a manner that 10%, which is 0.09 milligrams per kilo, is bolused over a minute, followed by the remainder, which is 0.81 milligrams per kilo, being infused over 60 minutes. Now, I would just like to remind you that alteplase is a fibrinolytic agent that can be used for acute ischemic stroke, for myocardial infarction, for PE, and for other acute thrombotic events. Now, there are numerous contraindications existing out there that significantly increase the patient's risk of bleeding, so you have to watch out for them. Now, I'd just like to mention as a by the way that other fibrinolytics include tenecteplase and reteplase, and neither of these two is FDA approved for use in acute ischemic stroke. So stick to alteplase. Let's move to the next question, please. Mr. BWL, a 69-year-old male patient, is diagnosed with acute ischemic stroke by your stroke team. His wife rushed him to your accident and emergency department 2.5 hours ago after his stroke symptoms ensued. Some of the vital signs include a heart rate of 89, a systolic blood pressure of 166 with a diastolic of 90, a respiratory rate of 16, and oxygen saturation of 99% on room air. The gentleman is febrile. His blood glucose levels are 38 milligrams per deciliter. So my question to you is, which of the interventions listed below would be the most ideal for Mr. BWL now? Would it be intra-arterial alteplase administered in such a manner that 10% is bolused over a minute, followed by the remainder being infused over an hour? Or would you opt to bolus 50% dextrose, a volume of 50 ml start? Or would you opt to administer IV alteplase in such a manner that 10% of the 0.9 milligrams per kilo dose is bolused over a minute, followed by the remainder being infused over 60 minutes? Or would you opt to administer IV TNKs in such a manner that 10% is administered via bolus over a minute, followed by the remainder being infused over an hour? I'll give you 10 seconds to choose the correct answer. I would bolus 50% dextrose. Now, while the correct dose for alteplase for acute ischemic stroke is 0.9 milligrams per kilo, in such a manner that 10% is bolused over a minute, followed by an hour IV infusion, the most appropriate intervention in resolving this gentleman's case is resolving his hypoglycemia. Now, clinically significant hypoglycemia can mimic stroke symptoms and can easily be detected and treated. So don't rush to bolus alteplase before you manage the sugars, the hypoglycemia. Now, if symptoms persist after the correction of the glucose, it may be appropriate to administer alteplase if no other contraindications exist. Now, I would like to remind you that 50% dextrose is a hypertonic solution, which is around 2.525 milliosmoles per liter, if I have estimated well. And despite being hypertonic, it's often administered by peripheral IV catheters. Now you need to do this cautiously. Should the dextrose 50% extravasate, it should be managed as a vesicant, including aspiration of the remaining solution from the catheter. You may choose to apply a cold compress and even consider hyaluronidase to avoid mass destruction of the tissue. Now, patients with altered mental status who are to receive IV dextrose should first receive IV thiamine. That's just a basic principle in many accident and emergency departments. Let's move to the next slide, please. The next question reads, which of the laboratory parameters listed below should be available prior to alteplase use in the treatment of an acute ischemic stroke that started within 180 minutes? That is within the past 180 minutes or 3 hours to be specific. Is it hemoglobin, glucose, INR, or serum creatinine? I'll give you 10 seconds to choose the correct answer. Glucose it is. Now, according to the American Stroke Association guidelines, the only test that must be done prior to the initiation of alteplase is a blood glucose test. And it should be greater than 50 milligrams per deciliter prior to initiation of alteplase. Now, while INR should be drawn in patients on warfarin, it isn't necessary to hold alteplase in patients who aren't on INR. So that makes C wrong. Hyperglycemia in the first 24 hours of an acute ischemic stroke is associated with worse outcomes than normal glycemia. So just remember that and manage the sugars well. Now, alteplase shouldn't be administered to patients who have received a full treatment dose of low molecular weight heparins within the previous 24 hours. There could be serious bleeding. Just as a by the way, let's move to the next slide, please. The next question reads, Mr. J.O.Z., a 76-year-old male patient with septic shock secondary to perforated diverticuli, is admitted to your hospital and is currently receiving an infusion of 2 grams of cefepime via IV piggyback over half an hour thrice daily, 500 milligrams of metronidazole via IV piggyback infused over an hour thrice daily, IV pantoprazole administered at a dose of 40 milligrams once a day, and as a vasopressor he is receiving norepinephrine at a dose of 25 mics per minute IV, together with midazolam at a dose of 2 milligrams per hour IV, and fentanyl at a dose of 50 mics per hour IV. And for thromboprophylaxis, he's been put on 40 milligrams of enoxaparin administered sub-Q once daily. Some of his vitals include a MAP of 6 to 7, a heart rate of 110, a respiratory rate of 20, an oxygen sat of 97%, and his body temperature is 100.1 degrees Fahrenheit. His RAS score is 2, where RAS stands for Richmond Agitation Sedation Scale. His BPS is 3, where BPS stands for Behavioral Pain Scale. And the CAM ICU is positive, where that stands for the Confusion Assessment Method for the ICU. Today, during the morning's spontaneous breathing trial, Mr. J.O.Z. became agitated and couldn't be extubated. So my question to you is, which of the medication modifications listed below would best suit Mr. J.O.Z. now? Would it be to order physiotherapy for daily mobility, or Would you choose to change Midazolam to Propofol, or would you change Midazolam to Dexmedetomidine, or would you choose to discontinue the fentanyl continuous infusion? I'll give you 10 seconds to choose the correct answer. Change Midazolam to Dexmedetomidine, and I'll tell you why. Mr. J O Z has hyperactive delirium, which is complicating attempts at extubating him. Now, Dexmedetomidine would provide anxiolytic properties with no depressant effect on the respiratory drive, and thus can be continued through the immediate period after extubation, where agitation may still be a concern. Now, I'd like to emphasize that non-benzodiazepine sedatives such as Propofol would be preferred to Midazolam, but upward titration of Propofol for agitation would suppress respiratory drive, which could complicate any attempt to extubate this gentleman. So I would not choose Propofol. Now, fentanyl should be continued considering pain is controlled based on the BPS score, and discontinuation could lead to further agitation and difficulty in weaning this patient. Now, initiation of early mobility is recommended by the Society of Critical Care Pain Agitation Delirium Guidelines. I would recommend you read them. Now, early mobilization has been shown to prevent delirium and to decrease the duration of delirium. Now, considering Mr. J O Z's current hemodynamic instability, that is, he still requires high doses of norepinephrine to maintain a MAP of above 65. Initiation of early mobility, in my opinion, would not be appropriate at this time. So I would consider answer A wrong. I would just like to remind you that the 2013 Society of Critical Care Pain Agitation Delirium Guidelines make a 2B recommendation to switch delirium patients not undergoing benzodiazepine or alcohol withdrawal from benzodiazepines in infusion form to Dexmedetomidine. Now, this recommendation is based on findings of lower prevalences of delirium in Dexmedetomidine versus lorazepam patients in what we call the SEDCOM, SEDCOM trial. And then there's also a trend towards more delirium-free days favoring the Dexmedetomidine cohort in what we call the MENDS, MENDS trial. Now, since the publications of the PAD guidelines and additional literature has been published identifying a potential niche for Dexmedetomidine in these patients, I would be biased towards switching to it. I would just like to remind you and caution you that the loading dose of Dexmedetomidine has been associated with hypertension and tachycardia due to transient peripheral vasoconstriction. Yeah, it may cause hypotension and tachycardia, so you have to load it wisely and carefully. Now, use of Dexmedetomidine in cardiac surgery patients resulted in decreased rates of new onset atrial fibrillation and lower rates of post-operative delirium, as well as shorter lengths of stay in the ICU and even intubation. However, these patients had higher rates of bradycardia and hypotension compared to those receiving Propofol. So weigh your benefits and risks before deciding on which mode of intervention to use. But for this particular case, I would switch Midazolam to Dexmedetomidine. Let's move to the next question. Mr. XPD, a 60-year-old male patient with an intracranial hemorrhage is receiving protamine sulfate to reverse heparin. My question to you is, which of the monitoring parameters listed below would be the most appropriate for Mr. XPD now? Would it be a point of care INR? Would it be activated clotting time? Would it be prothrombin time or platelet function assay? I'll give you 10 seconds to choose the correct answer. Activated clotting time it would be. Now, while the activated partial thromboplastin time, which we abbreviate as APTT, is used for clinical monitoring of heparin therapy, the activated clotting time, which we abbreviate as ACT, may be used for heparin overdose and or heparin reversal. That makes it the correct answer. Now, I would like to emphasize that high concentrations of heparin may cause the APTT to become unclottable, where the lab becomes insensitive or unsensitive. Now, the ACT's reliability is preserved regardless of the heparin concentration, so it's a more reliable marker. Now, the INR or prothrombin time assess the extrinsic pathway, and they don't adequately measure the full effect of heparin, and they can't assess the reversal of heparin either. I would just like to underscore the fact that platelet function assays do not provide enough information to appropriately adjust and interpret the reversal of heparin with protamine sulfate. Now, the ACT is a commonly used coagulation assay in clinical scenarios where high concentrations of heparin are used, such as in the cardiac surgery, for example, in cardiac interventions in the cath lab, in vascular surgery, or even in cases of overdose. I would like to emphasize that the prothrombin time is a marker of the extrinsic pathway. It is highly influenced by the plasma concentration of factor 7, and the APTT is a marker of the intrinsic and the common coagulation pathways. Now, in patients suffering from life-threatening hemorrhage, calcium is often overlooked by clinicians as a key therapy. It is required for the activation of the prothrombinase complex and the activation of factors 10A and 2A. So do not forget the calcium component when you are managing such patients. Let's move to the next question, please. JJM, a 68-year-old male patient, presents to your hospital. He has a past medical history of moderate to severe COPD, gout, hypertension, HFrEF, heart failure with reduced ejection fraction, where his ejection fraction is 35%, and your geriatric team diagnoses Alzheimer's disease in this gentleman. So my question to you is, which of the listed potential side effects would need to be given consideration about JJM's other medications when initiating rivastigmine for his Alzheimer's disease that has been newly diagnosed? Is it his heart rate or pulse will likely increase? Or is it true that he could develop worsening shortness of breath due to his COPD? Or is it true that he could develop obstructing uric acid nephrolithiasis? Or is it true that his risk for developing constipation will increase? I'll give you 10 seconds to choose the correct answer. So B is the correct answer. He could develop worsening shortness of breath due to his COPD. Now, rivastigmine, which is marketed as Exelon, is a centrally acting acetylcholinesterase inhibitor that is used for the treatment of Alzheimer's dementia. Now, due to its mechanism of action, the concentration of acetylcholine will increase in the CNS and thus increase the parasympathetic tone on other organ systems in this gentleman's body. And this could cause a reduction in pulse, that is, there is a potential bradycardia, especially if this patient is already on, say, a beta blocker for his heart failure. So there shouldn't be an increase in pulse. Now, there could also be an increase in peristaltic movements, and that can increase the risk of diarrhea, not constipation. Now, the stimulation of the GIT in such patients can also cause nausea and vomiting and dyspepsia. I would also just like to remind you and caution you that an increase in the risk of bronchoconstriction, especially in patients with pulmonary disease such as COPD in our patient's case, is usually treated with long-acting antimuscarinic or anticholinergic medications. Therefore, any drug that increases the parasympathetic tone due to the elevation of acetylcholine could increase the risks of bronchoconstriction or bronchospasms in such patients. So that would be a danger for this gentleman. And then the development of gout isn't related to any of these medications. So all those make me biased towards worsening of the shortness of breath. I would just like to digress a bit and mention that galantamine, which is marketed as Rasagiline, is another centrally acting acetylcholinesterase inhibitor that is used to treat the same disease, Alzheimer's dementia. So let's move to the next question, please. So the next question reads, Mr. N.A.K., a 75-year-old male with acute primary intracranial hemorrhage, presents to your hospital. He is currently on 5 milligrams of warfarin once daily. He is intubated, mechanical ventilated, and is beginning to show signs of increased intracranial pressure. Some of the vitals include a heart rate of 50, systolic blood pressure of 80, diastolic of 40, a respiratory rate of 16, and the oxygen sats are 98% on 60% FiO2. Some of his labs include a sodium of 141, chloride of 110, and a potassium of 4.2 milliequivalents per liter. So your neurosurgery team cannot attend to him now because they are currently surgically operating another patient. They are a bit committed, and they would like to administer hyperosmotic therapy for the time being before the current surgery is over. So my question to you is, which of the interventions listed below would be the most appropriate for Mr. N.A.K. now? Would you opt to administer 3% hypertonic saline at a volume of 250 ml over 15 minutes? Or would you choose to infuse normal saline at a dose of 30 ml per kilo over half an hour? Or would you choose to administer IV 200 ml of 23.4% sodium chloride over 15 minutes? Or would you prefer to infuse 250 ml of 20% mannitol over 15 minutes? I will give you 10 seconds to choose the correct answer. I would opt to infuse 250 ml of 3% hypertonic saline over 15 minutes. Now, the ideal hyperosmotic agent in this particular patient is 3% sodium chloride because it preserves the blood pressure and thus preserves by extension the cerebral perfusion. Now, mannitol, on the other hand, when administered rapidly, that is faster than 500 ml per hour, can cause vasodilation, and it also acts as an osmotic diuretic, which can further worsen hypoperfusion, can compromise cerebral perfusion as well. So it will not be the ideal one in this case. Now, normal saline 0.9% isn't hyperosmolar, and the volume of the 23.4% sodium chloride in this particular case, that's the 200 ml, is too high. Ideally, the appropriate volume is usually around 30 ml, according to many forms of literature out there. And then I would just like to underscore the fact that mannitol can be used to lower elevated intracranial pressure. However, it should be avoided if the systolic blood pressure is below 90. Remember, our patient's systolic blood pressure is at 80 millimeters of mercury. So mannitol would be a no-no in this particular case. And I would just like to remind you that mannitol requires storage at room temperature to avoid crystallization. It's a very conc solution, and it requires an inline filter while infusing to capture any crystals formed during the infusion process. And this is majorly aimed to prevent vascular trauma. The crystals could cut the linings of the blood vessels, so you have to be cautious. Let's move to the next question, please. It reads, which of the medications listed below is approved for the treatment of both Parkinson's disease and Restless Leg Syndrome, abbreviated as RLS? Is it Rasagiline, marketed as Azilect, or is it Ropinirole, marketed as Requip XL, or is it Entacapone, marketed as Comtan, or is it D, Selegiline, marketed as Zelepar? I'll give you 10 seconds to choose the correct answer. So Ropinirole or Requip it is. Now Ropinirole is a dopamine agonist that is indicated in PD, that is Parkinson's disease, and RLS, Restless Leg Syndrome. Now Rasagiline, on the other hand, is a type B monoamine oxidase inhibitor used in the treatment of PD only. And Entacapone is a COMT inhibitor used in the treatment of PD only, Parkinson's disease only. And Selegiline is a type B monoamine oxidase inhibitor used for the treatment of PD only. And that is when it's in the oral formulation. Now there are also transdermal patches that are used for the management of depression, just as a by the way. Let's move to the next question. It reads, Cabergoline can be used as a last line option in the treatment of RLS. It is an ergot alkaloid. Its use is limited by risks for serious adverse effects. So my question to you is, which of the serious or dose limiting side effects listed below is associated with cabergoline? Is it severe nausea, cardiac valvopathy, orthostatic hypotension, or all of the above? I'll give you 10 seconds to choose the correct answer. So all the above apply. We know that cabergoline is an ergot derivative which has been associated with cardiac valve disorders. Now, patients should receive cardiac evaluation with a chest x-ray and an echocardiogram at baseline before this drug is initiated. And its use is contraindicated in patients with a history of cardiac valve disorders. Now, it often causes nausea in 27 to 29% of patients based on clinical data available out there. So we should avoid dopamine blocking anti-nausea medications such as promethazine, haloperidol, and metoclopramide, since they interact with cabergoline's mechanism of action. Now, cabergoline can cause dose-dependent orthostatic hypotension in around 4% patients, according to clinical trial data available out there in publications. Now, starting with the lower doses and titrating slowly can be beneficial when you're using this drug in therapy. Let's move to the next slide, please. Our last question reads, Mrs. WSR, a 67-year-old female patient, presents to your hospital with intracerebral hemorrhage, ICH. 30 days ago, a month ago, she received alteplase for an acute ischemic stroke at your accidental emergency, with an improvement in neurological function, and was discharged on enoxaparin at a dose of 60 milligrams to be administered sub-Q twice a day, with an intention of bridging to oral anticoagulation, but it never happened. She is still receiving enoxaparin, but now presents to your accidental emergency department with actually worsening neurologic deficits, and is found to have a new ICH, an intracerebral hemorrhage again. Bad luck for her. So my question to you is, which of the following interventions would be the most appropriate for Mrs. WSR now? Would you administer vitamin K? Would you administer Kcentra? Would you opt for Idarucizumab, or would you administer Protamine sulfate? I'll give you 10 seconds to choose the correct answer. So both answers B and D are correct. Kcentra and protamine sulfate are both correct answers in this particular emergency. Now, protamine sulfate is an appropriate reversal agent for low molecular weight heparins. Now, although there is limited data in literature, prothrombin complex concentrations such as Kcentra, alternative B, may be used to reverse the anticoagulant effects of low molecular weight heparins. Now, the dosing recommendation is 1 milligram protamine sulfate for every 100 anti-10A units of low molecular weight heparins. Now, if you look at enoxaparin, for example, 1 milligram corresponds to 100 anti-10A units. Now, that dosage should be used if the low molecular weight was administered over the previous 8 hours, and the maximum protamine sulfate dose should be 50 milligrams. You should not cross the 50 milligram mark, irrespective of the patient's weight. Now, if more than 8 hours have elapsed since the last low molecular weight heparin dose, the protamine dose should be decreased to 0.5 milligrams for every 100 anti-10A low molecular weight heparin units that were administered previously. Now, protamine sulfate itself can paradoxically elicit anticoagulant effect through the reduction in the rate of factor 5 activation. So be very careful. That's why we have a ceiling of 50 and never exceed it. Now, rapid administration can cause profound hypotension, so administer your protamine sulfate carefully and cautiously. It can also lead to bradycardia, pulmonary vasoconstriction, and even transient neutropenia. So use protamine sulfate with caution in such patients. So my highly esteemed viewers and listeners, that brings us to the end of this video. If this video benefited you in any way, I would like to urge you to please remember to give it a thumbs up and to like it and to share it widely with your peers. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you that the best is yet to come. I thank you very much for viewing and for listening to this video. I sincerely appreciate your partnership and your continued support and very kind collaboration. And I look forward to interacting with you people in part 53 of our Pharmacotherapy MCQ series. Thank you very much for always being there for me.